Hello, dear friends. I am Dr. Denis Fedorenko. I am hematologist and from Pirogov Medical Surgical Center, and I am responsible for autologous stem cell transplantation for autoimmune disease patients. And the topic of our webinar today is high-dose immunosuppressive therapy with transplantation for multiple sclerosis patients. I am going to talk about our experience, the principles of transplantation, and answer some of your interesting questions. Hello, Gwen. Nice to see you.
Hello, Dr. Fedorenko. It's very nice to see you.
I'm happy that you are doing well, and let's follow our plan and start with presentation. I would like to share our experience, our transplantation experience, and to inform about basic principles of transplantation and effective treatment of multiple sclerosis. So I'm very happy to see you again. Thank you very much.
My pleasure.
And dear friends, Dear friends, the topic of our presentation is transplantation for multiple sclerosis patients, our center experience. And lots of patients know our center, and Maximov Department of Hematology was created in 2003, and we started our transplantation activity in 2005. Till today, we have provided more than 2,000 transplantations for hematological malignancies and autoimmune disease patients, mainly for multiple sclerosis. Why our center named after Maximov? Alexander Maximov was a famous Russian histologist who created stem cell theory. It's important for transplantation because we provide stem cell transplantation. And another famous professor, Professor Andrei Novik, was a founder of transplantation approach for autoimmune disease patients in Russia. Some words about history of transplantation. Big slide, please. And the first period, firstly, transplantation was developed for hematological malignancies, and this is anti-cancer treatment. And when hematologists started to treat leukemia or other diseases, they noticed that some patients who had two diseases, leukemia, lymphoma, and other autoimmune diseases together with multiple sclerosis, after successful treatment cancer, they treated successfully multiple sclerosis. The next step was the period of research, animal research, and organization of working group in the USA and Europe, working committee on stem cell transplant for autoimmune disease. It was 1995. The first transplantation for multiple sclerosis in the world was provided by Professor Fassas in Thessaloniki in 1997, in the USA, in Chicago in 1998. Our center provided transplantation in 1999 by Professor Andrei Novik. First transplantation in Russia. You know that multiple sclerosis is chronic incurable autoimmune disease, and approximately more than 3 million individuals worldwide are affected. There are no any evidence that standard treatment or immunomodulating treatment can prevent patients' disability. Conventional treatment only can't provide satisfactory control of multiple sclerosis due to inability to create cell-specific T-cell clones. Transplantation is based on idea that high-dose chemotherapy ablate wrong immune system and renew new immune system using hematopoietic stem cells. Till today, all around the world, more than 2,000 transplantations for multiple sclerosis have been provided. The main target, what affects transplantation? The main target is autoreactive T and B lymphocytes clones. High-dose chemotherapy eradicate pools, clones of wrong immune cells. 7 steps of transplantation. First step is stem cell mobilization. Firstly, we need to collect stem cells. Second stage is stem cell harvesting or collection. Then we provide defreezing in liquid nitrogen. And the most important part of transplantation is high-dose immunosuppression. We use cyclophosphamide-based protocol, but lots of centers use another protocols. And then stem cell reinfusion with monoclonal antibodies or without it, and important stage, hematological and immunological recovery. First stage usually takes about 1 week. This is stem cell mobilization and collection. High-dose immunosuppressive therapy takes from 4 to 7 days depending on the protocol, and then stem cell reinfusion and hematological immunological recovery, it's about 7-10 days. And another important stage, which is outpatient stage, is rehabilitation and sometimes consolidation on top of treatment. Why transplantation? Why we would like to talk about transplantation? Why this approach is getting more and more popular? American Autoimmune-Related Disease Association, Professor Richard Noel, the famous immunologist, postulated, in my opinion, the only way we are going to develop really effective treatment will be to treat the cause of the disease, not the symptoms. And the same phrase, treating the symptoms after the disease, has had its destructive effects. Professor Noel is a great immunologist, and this is right understanding that when we treat autoimmune diseases, we need to affect the reason of the disease, but not the symptoms or not the result of the disease. Nowadays, lots of standard approaches in neurology to treat multiple sclerosis, from steroids to immunosuppressants, immunomodulatory treatment, monoclonal antibodies, very modern, like rituximab, Ocrevus, Zimbrita, Lemtrada, Tysabri. But what means effective treatment of multiple sclerosis? Firstly, we should really understand what means effective treatment. Our position is that effective treatment is to stop multiple sclerosis progression for a long period. This is about years. To prevent irreversible CNS damage and critical disability of patients, to improve significantly neurological deficit for long period, years. This is what we have to reach when we use effective treatment. Non-effective treatment, this is decreased rate of inflammation, decreased number of size of lesions, and decreased number of relapses per year, and other surrogate aims. We can see that transplantation can reach these aims of treatment. All disease-modifying drugs can't stop the disease and can't prevent disability. Nowadays it's clear. Firstly, we should ask 2 main questions. Can we cure MS using standard treatment? The answer is impossible. Can we prevent? The answer is impossible. And why? It's clear, all disease-modifying drugs are not able to eliminate autoreactive T and B lymphocytes clones. So our disease-modifying drugs can't remove wrong immune system. So we need principally new approach for multiple sclerosis treatment. And the new approach is based using more intensive program, treatment intensification. I would like to tell some words about theory of treatment intensification. T toxicity, E effectiveness. All disease-modifying drugs, as we discussed previously, are in area of low effectiveness. They can reach only surrogate aims. So we need to increase effectiveness, so we need to provide treatment intensification. How can we do it? Treatment intensifications based on two main important things. Increase summary dose intensification, and decrease intervals between courses, dose density. So treatment intensification is based dose intensification and dose density. Transplantation is like a hit, chemotherapy concentration for short period of time. For example, dose density. Cyclophosphamide, 200 milligrams per kilogram body weight is widely used protocol. Not the same for 4 days, isn't the same that the same dose for 8-12 days because of chemotherapy elimination, less concentration, less dose density. Dose density is important part and basement of transplantation. If we give more intensive dose, some patient ask me, we would like to have the most intensive, the most aggressive treatment. If we go ahead and increase intensity more, we go to area of high toxicity. This area is quite dangerous. We should carefully assess risk and benefits and find the best balance between effectiveness and toxicity. An area of the best balance between effectiveness and toxicity is lymphoablative transplantation. It's here between area of low effectiveness and area of high toxicity. One of the key questions, what is the appropriate time for transplantation? We developed conception of 3 variants of transplantation and 3 strategies of transplantation for multiple sclerosis. It's quite interesting because lots of patients ask when we should do it. Should we wait or not? And our position is early transplantation. The goal of this treatment to prevent damage of the CNS, to prevent disability and to save patients' quality of life. Early transplantation is provided when a DSS score 1 to 3. The most common transplantation is conventional transplantation with a DSS score 3.5, 6.5. And the main goal of this treatment is to prevent the disease progression in patients with neural damage, with partial loss of functioning, to stop the disease and to prevent further disability and to improve patients' quality of life. And very difficult transplantation, salvage transplantation for critically disabled patients with a DSS score 7 to 8.5. And the main goal of this treatment is to stop the disease progression in patients with irreversible neural damage, with significant loss of functions, to save patients from complete disability, and to improve severely declined patients' quality of life. I would like to tell some words about our center experience. As a study of our clinical trial was to analyze patient-reported outcomes and clinical outcomes of MS patients using lymphoablative protocol. When we assess treatment outcomes, we use dichotomic technologies. We assess clinical response based on traditional neurological assessment and MRI, and of course patient-reported outcomes, quality of life and symptoms. For clinical response, we use standard methodology. For transplantation, we use the follow program, mobilization GCSF, standard approach for 5 days, then leukapheresis using special machine for stem cell collection, high dose immunosuppression using lymphoablative protocol. We use cyclophosphamide 200 milligram per kilogram body weight for 4 days in combination with rituximab. We analyzed more than 800 patients. 2/3 of patients had relapsing remitting multiple sclerosis, but interesting to notice that we included patients with primary and secondary progressive multiple sclerosis. Long-term side effects. Tragically, we had mortality. The mortality rate is 0.3%. We lost 3 of our friends. And lots of centers is about 1%, but mortality is still here because to give effective treatment, we need to destroy all wrong immune system. If we do it, we take some risk. But long-term effects quite predictable and control. This is fatigue and alopecia. Event-free survival for whole group. A 5-year event-free survival for whole group, more than 800 patients, is 87%. It's great, it's amazing result for my opinion. But there is a differences between relapsing remitting and progressive variants of MS. Relapsing remitting MS patients had event-free survival more than 90%, progressive 78%, also high. Also, when we analyzed quality of life, we noticed that patients who had early transplantation, patients' quality of life improved dramatically and during 1 year reached population norms. Red diagram, quality of life before transplantation, and then improved dramatically to during first year after, and quality of life was good during a long-term period of follow-up. In conventional, in disabled patients, quality of life also improved, but didn't reach population norms. So it give us additional improvement that we need to provide transplantation as early as possible. And a summary of our study, we consider that transplantation is promising and quite effective approach. More than 70–80% of patients may have positive result of this transplantation, and we found that the favorable factors is early transplantation, younger, old, and short disease duration, and relapsing remitting multiple sclerosis. For majority of patients, we haven't had any severe side effects. Also, transplantation can improve quality of life of all groups of patients. Primary and secondary progressive multiple sclerosis. I had lots of questions why we include patients with secondary and primary progressive multiple sclerosis. Is this treatment effective for this group of patients? Because it's considered that patients have neurodegeneration and relapsing remitting patients have inflammation. It's not true. Department of Neuroimmunology in Vienna provided the research relationship between inflammation and neurodegeneration in multiple sclerosis patients. And they found amazing result. They found that pronounced inflammation in the brain isn't only present in acute relapsing remitting sclerosis, but also in secondary and primary progressive disease. So not only relapsing remitting early stage MS patients have inflammation, but secondary and primary progressive disease patients. So we can treat these patients using transplantation. And so we provide two critical therapeutic effects: complete control of immune-mediated inflammation in brain tissue, because we have it in this group of patients, and we reset immune system to stop the disease and to prevent inflammation. And I would like to demonstrate two cases of progressive variants of MS. This is our patients, our old patients. Now they're healthy person, one male 37 years old with secondary progressive multiple sclerosis during 5 years. Before transplantation, patient had lots of variants Standard treatment EDSS score was 6.46. Transplantation was provided in 2007, and now follow-up period is almost 10 years. In 10 months after transplantation, EDSS score improved dramatically by 4 points from 6 to 2. Brain MRI stabilization. This is patient before transplantation, skating after transplantation, EDSS 2, and parachute jumping. So patient has normal quality of life. Another patient, Natalia, this is second transplantation in Russia, was provided in 2000. 1 year after transplantation, she had EDSS 3. Before transplantation, EDSS was 6. Also progressive variant of multiple sclerosis. Natalia 4 years after transplantation. 3 and 10 years after transplantation, this beautiful lady had EDSS 1. And 10 years after transplantation, we celebrated it. It was 2010. Now we are going to celebrate almost 20 years anniversary of this event. This is Professor Andrei Novik with children from our patients who had transplantation, and our patients' organization New Life, which started in 2009, and the main aim of this organization to support each other, to support patients, and to widespread information about this effective approach. And perspective, our center is developing lots of new technologies, and we are going to use it in routine clinical practice. And first one, we are developing new lymphoablative conditioning regimens, new consolidation top of treatment in case of aggressive multiple sclerosis and other specific situations. Also, we are going to combine transplantation with intrathecal chemotherapy or immunotherapy, and also to combine transplantation with stem cell technologies with mesenchymal or T-regulatory cells. And I would like to say that transplantation isn't only medical treatment. I like Confucius' phrase, the will to win, the desire to succeed, the urge to reach their full potential. These are the keys that will unlock the door to personal excellence. To fight incurable disease, we need not only use modern technologies we discuss now, but also spend all our energy, all our motivation, and work hard in combination with transplantation to fight the disease. Motivation and transplantation are key point of effective treatment. Thank you very much for your attention.
Thank you so much, Dr. Fedorenko. That was very interesting and very enlightening. Thank you very much.
Thank you, Gwen. Thank you. Nice to see you again. And so, if you have any questions, I would be happy to answer.
My very first question is to ask, what type of autoimmune diseases can be treated with HSCT, please? I believe there are other diseases, not just MS. Could you enlighten us a bit more about that, please?
Yes, thank you very much. Because the mechanism of all autoimmune disease is same, only targets are different. We can treat lots of variants of autoimmune disease. Firstly, other neurological conditions like stiff person syndrome or CIDP, rheumatic diseases like rheumatoid arthritis, lupus, and systemic sclerosis, and bowel autoimmune diseases. The transplantation is quite effective for Crohn's disease. We have experience in rheumatic diseases, in CIDP, and in bowel autoimmune diseases.
Oh, that's fantastic. Are there any autoimmune diseases which cannot be used, be treated by HSCT?
only local autoimmune diseases like thyroiditis. Also, we consider that diabetes type 1 is a good option for transplantation, and also ulcerative colitis is a good option for transplantation. And because in some diseases, targets are quickly destroyed and transplantation can cause good result. Another thing, some autoimmune disease have mixed mechanism, like ankylosing spondyloarthritis is a good model for transplantation because it's not only autoimmune disease but also some degenerative disease and unknown mechanism of this disease, and our experience is quite lagged, but the success rate is about only 30%. We provided first transplantation in the world more than 10 years ago, but success rate for ankylosing spondyloarthritis is about 30%, so we don't think it's effective treatment.
Thank you. Thank you for that. When people think about chemotherapy during this treatment, they're afraid that it's going to be difficult or uncomfortable. Do you find that it is really that bad for people? And if it is, how do you manage those symptoms?
Usually modern chemotherapy is easily tolerated, and we use very powerful supportive treatment, and we need to control symptoms, of course. We use feedback from patients, and we control all symptoms which are related to chemotherapy, like nausea, vomiting, discomfort, fatigue, pain. So we have all opportunities to take these symptoms under control. So I think it's not difficult.
Oh, that's wonderful. That's wonderful. How long do you think that HSCT is mostly effective for stopping autoimmune diseases? You think it is a really long-term solution to the problem?
We discussed in our presentation about the science of effective treatment, of course, long-term, yes. And our first and second transplantation, 1999 and 2000, are in remission now, so maybe for some patients for whole life.
That's amazing. That's great.
But of course for a long period.
That's great. And do you think that that most of the improvement that one is likely to get is soon after the treatment, or is it likely to continue to improve after, say, 2 years?
It depends on the disease cause. The most progressive, the quicker disease, the quicker improvement. This is a kind of rule, but remyelination is also possible, and the earlier provide transplantation, the better, and the sooner recovery. But usually recovery takes about 1.5 years.
Thank you. And some of the questions that are asked by people who have had HSCT in some of the HSCT forums, people ask, why do you say not to have vaccinations after HSCT? What is the reason for that?
It's important questions because hematologists started to use HSCT for autoimmune disease patients, and the common rule in transplantation to provide revaccination. But this is mainly for cancer patients. Autoimmune disease patients is different group of patients. And sometimes autoimmune disease starts after vaccination. So vaccine in 6-12 months after autoimmune disease. We consider that vaccination or revaccination give additional risk of relapse. Of course, vaccination isn't prohibited. If patient really need it, if it's important for patient's life, vaccination should be done. But we don't recommend revaccination or unnecessary vaccinations, like flu shots without any serious reasons and other. Also, lymphoablative protocol safe immune memory.
Thank you. And finally, we often get asked, how important is it that people have MRIs after HSCT, if they feel well, do they need to have an MRI at any point?
We need to control the disease, especially in early post-transplant period. Sometimes patient feels good, but MRI is on MRI we can see new or active lesions because MRI can detect new lesions before clinical picture. And to make decision in time, we recommend to control MRI in 3-6 months period. Also, another side, we need to assess effect, how, especially in active patients before transplantation, how patient improved. Maybe we need additional top of treatment for highly aggressive MS, and we make this decision based on first MRI. So this is why we need MRI. But usually MRI rate is, if everything is okay, once a year is enough. But we strongly recommend to use contrast.
Thank you very much.
Thank you very much, Gwen. Thank you very much for your support. It's so
My
nice
pleasure.
to see you again, and I wish you to have a nice evening and to be strong and healthy.
Thank you. Thank you so much.
Bye-bye.
I am very grateful to you.
Thank you.
Bye-bye.
Thank you for support of our approach. Thank you. So, dear friends, we are going to discuss our questions from our other friends and from UK and from to ask some questions we have now from website. Okay. Oh, hello, Janet. Nice
Hello,
to
Dr.
see you.
Fedorenko.
Nice to see
Hi,
you. How are you doing?
Is that better yet?
Okay.
That's
Okay.
it.
Janet,
Hello.
I'm
Lovely to see
happy
you.
to answer questions you have.
Okay. The first question was really for people who are thinking about having HSCT, and I know from my experience that the fear of the unknown was the really scariest thing. So I wanted to know how the treatment would make me feel and what possible reactions I might have. And I know that when I was actually having treatment with you, that I felt very safe and well cared for. But to put people's mind at rest, can you explain a little bit about the main side effects and possible complications during the treatment and how you would manage those for your patients?
Okay. Transplantation is intensive treatment, and the safety of transplantation depends on team and center. The more experienced center, the more experienced team, the safer transplantation. For example, in our center, we have provided more than 1,000 transplantations, so we have good experience. We know what to do in each side for each side effects. Also, we consider that transplantation should be done only in big governmental university center. For example, in our center, we have lots of specialists like surgeries, gynecologists, neurologists, and we work in cooperation. It's important. We have all modern equipment and all other specialists in case of complications. Of course, the risk of complication is still here. It's about 0.3–0.5% to have dangerous life-threatening complication, but we are developing technologies to predict it. Mainly it's infection, sometimes bleeding, and neutropenic fever, and discomfort, fatigue, and diarrhea. But the most dangerous is infection. So the best infection control is the most important thing in transplantation.
Okay, thank you.
You're welcome.
Then next question I had was do you have a top 3 list of risks for people to avoid after transplantation?
Excuse me?
Do you have a list of a sort of a top 3 list of risks that people should avoid after transplantation?
I can understand. You mean people who should avoid transplantation? Yes, of course, we provide careful examination, and we don't recommend transplantation for very disabled, for fragile patients, and we provide assessment of heart, lung, and we don't provide transplantation if we see that it's quite risky. And if risk more than benefits, we don't go ahead.
Okay.
So transplantation, I think, is prohibited for very disabled patients, especially if it isn't acute relapse. If patient is disabled for long period of time, it's yes. And of course, if patient has comorbidities or diseases more difficult and more dangerous than autoimmune conditions or multiple sclerosis.
And when people have had their transplant, what should they avoid after transplantation?
I understand. Of course, during first 3 months, we don't recommend to contact sick persons, to be careful in public places. We don't recommend active sunbathing. Of course, we don't recommend vaccination. And take it easy. We recommend to follow healthy lifestyle. This is healthy food, good level, high level of motivation, active lifestyle. But for early period, we don't recommend too intensive exercising.
That leads into my last question, which is about exercise and rehabilitation afterwards. I found it very difficult knowing how hard to push myself and what exercise to do. Do you have sort of recommendations about that?
My recommendation is try feel your body, listen to your body, when to start. If you're tired, exhausted, and have symptoms after transplantation, wait. And when you feel that you are ready, you have enough energy, start. But there are 2 rules for exercising. To do it regularly, not 1 week, for example, twice a day, 1 week nothing, no body stress. And increase intensity step by step. After exercising, you should be tired but not exhausted. And of course, I recommend to find specialists and to exercise, to have rehabilitation under control of physiotherapists and specialists. I think it's important, especially for patients who lost some functioning.
Yeah, I with that, I would say I definitely agree. When I found a good neurological physiotherapist, that really has helped me a lot.
I agree with you. Physiotherapy under control of specialists is the most important thing, because transplantation is only part of complex treatment. Another part is exercising, healthy lifestyle, healthy diet, positive mind, family and friends support, hobby, and of course activity.
Yeah, absolutely. Holistic approach.
Yes, yes. 2 cases I demonstrated, 2 patients with progressive multiple sclerosis, Russian patients, had great success because they had high level of motivation and they knew why they need to fight MS.
Yeah.
They had motivation. So this is what I recommend for all our friends.
Brilliant. Thank you very much indeed, Doctor.
Thank you. Have a nice
Lovely
evening.
to see you again.
Thank you. Thank you, Janet. So Janet asked lots of beautiful and interesting questions. I think we cover lots of topics from website, and if you have another questions, I am ready to answer. So, oh, another our friend Han Wilson is coming.
Hi, I can hear you.
Oh, hi. And hi. Do you see me?
I can
Okay.
see you.
Maybe you should switch video on camera because I can hear you but I can't see you.
Is that better?
It's no. Oh, it's better. And now, good evening. Nice to see you. You look
Hi.
nice. And so, what questions do you have for me?
Great. Well, first of all, I missed the beginning of the. Let me just turn that down a bit. The presentation, but thank you so much for all you're doing for all of us. You're fantastic, and I know there's a lot of people that have followed my journey, and that they've asked me lots and lots of questions, and that they're watching tonight. And I'm very soon, as you know, post HSCT. I only had it on the 24th of October. So anybody that wants to personally message me, I'm more than happy to chat to people. But my first question with being post HSCT is that quite a few of the people that I was there with got or are suffering with shingles, and wondered if you could explain to us why you don't give acyclovir as a discharge medication.
We stopped to use prophylaxis because we provided research. We make personal decision about prophylaxis. If a patient has a high risk of shingle infection or bacterial infection, we give this prophylaxis. If not, we watch and wait and give treatment only in case of infection, because we didn't find any differences between two groups of patients who had prophylaxis and who didn't have it. So, on the other hand, some patients had lots of side effects from long-term prophylaxis, so we stopped it. But we recommend prophylaxis for separate group of patients. We make personal decision about it. So, if patient had infection during transplantation, if patient is disabled and has high risk of urinary tract infection, or if patient has high risk of herpes or shingles infection, we give prophylaxis, but it's not all patients. Thank you.
Okay. Also, you recently published in November of this year the success rates for the HSCT in Russia, and that was where you put that relapsing remitting MS patients were 85 to 95%, secondary progressive 70-76%, primary progressive 65 to 75%. How did you get this data, and what is it based on? Is it the success of HSCT? Is it success of stopping progression? What does it mean by the success rates? Is it just success in achieving improvement? What is the actual success rate that is?
There are traditional criteria for HSCT assessment. This is criteria of European bone marrow transplantation group. This is stabilization or improvement. If we stop, we are successful. If we improved, we are successful. And assessment is based on MRI and neurological status. We analyzed more than 800 patients, and this is our statistic. And we analyzed primary, secondary progressive patients and relapsing remitting, and found the result for relapsing remitting is better for progressive. And numbers we publish are based on our statistical research. We send special forms for patients who live far from our hospital. For Russian patients, we invited for follow-up visits. So this is our statistic.
Is that ongoing? Do you collect that data ongoing, or was that just a particular study?
Of course, yes. We try to provide long-term follow-up. We send special forms to our friends regularly. Also, we ask for MRI data for neurological assessment from all our friends, and I am receiving lots of information from our friends, and we are collecting this data and analyzing it. So I think we will have more information about percent rate soon.
Okay. Somebody was asking earlier on the live chat whether it was okay for secondary progressive patients with an EDSS of 6.5 that have had MS for greater than 15 years. I want to say to that person myself that I was that patient. I had MS for 22 years with an EDSS of 6.5, and I've gone ahead with that. And I just wanted you to clarify that for the people watching, that it is okay for people with an EDSS of up to 6.5.
We provide transplantation for very disabled patients as a salvage transplantation, but we make personal decision after examination.
Yeah.
We should take into account patient visions, general health, risk and benefits. Of course, as we discuss, also in late stage of the disease, of progressive stage of the disease, patient has part of inflammation. And sometimes we can improve patient's quality of life. So we can provide transplantation in late stage of the disease, and we have this experience. Of course, it's not good if a DSS score more than 7 or 7.5, but if we see that we can help, the risk and less than positive thing, we can provide this treatment. We should carefully assess risk and benefits in each situation. So this is the main idea.
Absolutely. And really just reinforcing what you said and finished off with Carol, the fact that positive thinking and that working together, you can provide us with a new immune system. We have to do the rest of the work, have that positive thinking and that motivation. And if we can have a good neurophysiotherapy service at the same time, that's great. But you're right, it's the patients who've got the positive thinking, who are able to take their health into their own hands. Get out there, get yourselves exercising, keep positive, are going to do well. And you've proven that time and time again.
I absolutely agree. Rehabilitation is very important. And I think lots of other technologies in rehabilitation should be used, like music therapy, art therapy, yoga, lots of other technologies, meditation and rehabilitation under control of specialists, especially for disabled patients, because transplantation only reboot immune system. Another part of treatment is the same important. And unfortunately, lots of specialists don't put enough attention for rehabilitation, for treatment after transplantation. We need to do it, and we need to work hard after transplantation also.
Absolutely. I think as people are becoming more aware, there are certainly, I'm finding over here in the UK, neurologists are becoming more and more interested now. So hopefully we can raise awareness with things like this and get those neurologists on board and get them to send people for that rehab.
I'm very happy that the situation is changing, and we are ready for cooperation with Neurological Society. We are open, so welcome. And thank you very much for your support.
Thank you so much.
Thank you. Bye-bye. Have a nice evening.
Thank you.
Thank you, dear friends. Maybe if you have other questions from the internet, and Anastasia, And I think everybody knows her. She is my assistant and she is administrator of hospital. So, and maybe she has some questions for me.
Yeah, hello to everybody. Nice to see you. Okay.
Hello.
And to see your interesting question. And to be honest, one of the most popular and really quite often question everywhere between our patient and hospital, and as I see on Facebook, look, doctor, if patient has GCV positive, could be a problem for treatment at all, for chemotherapy?
GCV antibody positivity isn't a problem for transplantation.
That's all.
If patient has GCV virus, antibody to GC virus, it's not a problem for transplantation. It's problem for antibody therapy. But we treat mainly by chemotherapy. Of course, we analyze all factors. Also, we test patients with high risk of PML infection and make personal decision. But lots of our patients GCV positive, and we haven't had any PML infection after transplantation.
All right, thank you. And another question about chemotherapy, also quite interesting. Can the dose of chemotherapy be reduced to minimize risk of long-term effects? Is it possible to
Reduce dose to
Yeah.
minimize. We use optimal dose of chemotherapy. If we reduce dose, we can decrease positive result. So now we use well-balanced protocol with good balance, effectiveness and toxicity. If we decrease dose for some reasons, we of course decrease effectiveness of transplantation. I think we can do it, but for very specific situation. And for this patient, we usually use consolidation on top of treatment during first year after transplantation. But we don't share this approach. We consider transplantation should be intensive enough.
Okay, thank you so much.
You're welcome.
Also quite interesting and new question about second transplantation. What reason, when should we provide it and organize?
We provide second transplantation as a good treatment option if patient responded for first transplantation and relapsed, especially in more than 1 year period. And we developed special protocol with another chemotherapy and combine this chemotherapy with intrathecal chemotherapy. We use lumbar puncture and use chemotherapy inside of central nerve system. We give this transplantation and second choice after relapse after first transplantation.
Okay, thank you. Also quite interesting question about doses, not about chemotherapy right now, but dose about steroids. Is it possible also to reduce dose or maybe do it?
Yes, of course, it's possible to reduce dose or not to use steroids. Steroids is only treatment to make transplantation easy, to treat transplantation-related symptoms. Like nausea, fatigue, it's a part of anti-nausea protocol. We can reduce steroids doses. Sometimes we don't use steroids because of diabetes on high level of blood sugar in some patients, so it's possible.
Okay, thank you. Another interesting and quite often also question, why do we accept patient without active lesion? Is it the main reason or not? Because in many centers around the world, it's an obligatory reason to get a treatment.
Yeah, firstly, we included patients only with active lesions. This is clinical trial rules. Now our center in clinical practice stage. To be honest, it's very interesting questions because sometimes, let's imagine patient has relapse. We provide MRI, no active lesions. We give steroids, anti-inflammatory treatment, and have positive result, but no active lesions. How to explain? How to explain that sometimes MRI can't see activity, can't see inflammation. Inflammation can be on cellular level, and patient, for example, primary progressive patient, has progression without active lesions. So does it mean that patient doesn't have inflammation? No. Patient has inflammation which isn't detectable on MRI. Inflammation can be on cellular level. Also, our decision based on our research. We analyzed two groups of patients who had active lesions before transplantation and who didn't have it. No differences in long-term positive result. So the more important is disease cause. If patient has disease progression, patient has inflammation. Inflammation can be detectable when we can see active lesions or not detectable, and it doesn't matter for us.
Okay, thank you. And may I ask the last question and the most popular, I think, over our internet or all pages? Why do we use non-myelablative protocol, not BEAM?
Because we don't need to destroy myeloid part of bone marrow. We need to destroy only immune system. BEAM myeloablative protocol and lymphoablative protocol provide the same immunoablation and the same effect on immune system. But BEAM myeloablative protocol is more dangerous and has more side effects. You can find information, Brazilian experience, and compared to protocols, cyclophosphamide-based and BEAM protocol. No differences in positive result, but big differences in mortality rate. Also, when we treat chronic disease, we should carefully assess risk and benefits. If we give too strong, we can make worse than MS. And we should think about long-term quality of life. But we consider that effectiveness of lymphoablative and myeloablative for autoimmune disease patient is the same. But toxicity is much higher in BEAM group.
So that's all. Thank you so
If,
much.
dear friends, if we discuss all questions, I'm very thankful for your interest to our presentation, and I am very thankful for our friends, Gwen, Jeanette, and Anne, and all our friends for interesting questions. And I wish all friends, all MS patients to make right decision and to choose active way to fight the disease, because when we face this disease, we have two ways, active and passive. When we choose active way, we should go ahead spending all our energy and using all our motivation to find the disease. This is not only about transplantation. Transplantation is effective, but it's not enough to fight the disease. We should combine it with our energy and our motivation and our healthy lifestyle. I wish all our friends to be successful and strong enough to do it. Thank you very much and have a nice evening, maybe morning.
Скажи на вопросы, ответь.
And of course, I think we didn't answer all questions. We have some personal questions. We will answer personally via email. My assistant told me that we have some private, some personal questions. We will answer all our questions. And thank you very much for your attention.